There are lots of unanswered questions about the coronavirus, and anyone that says to you that they know,
they're talking crap.
I think they're being economical with the truth. I don't think it's possible to lock down societies. If you lock down a society, as soon as you open it, the virus will come in. We don't know how effective or useful coronavirus vaccines are going to be if we ever get a vaccine that works. We don't know which antibodies are protective and how long they're going to be protective for. People often believe that if they've had a test, that there's 100% certainty around whether it's positive or negative.
Okay.
There is not. And whether you can get the virus, whether you can get the infection again.
Hey, welcome to another episode of Voices in My Head. It's been a while since the last podcast episode because I wanted to get the right person to you. And also, I was taking a bit of a break. I've been working on getting my book out. The book is also called Voices in My Head. It's going to be available in a couple of weeks as soon as this lockdown situation eases up a bit and the distribution of the books can go back on Amazon and the other platforms. The Kindle version will also be available shortly. So please do get it. Tell me what you think. Your feedback and your views and your reviews would mean a lot to me. I have Dr. Arun Menon with me on the podcast today. He is the right person to answer all the questions I have about coronavirus, COVID-19, etc., all the misinformation, confusion that exists if you look at mainstream media telling us one thing when another expert is saying something else. I want to ask him about masks. I want to ask him about vaccines. I want to ask him about several things. So that's coming up shortly. To introduce Dr. Arun Menon to you, he's an expert on public health, and epidemiology is a part of public health. He's trained in public health, tropical and sexual health medicine. He's a director of 3 sexual health units in regional and remote Australia. He's the adjunct associate professor at James Cook University, Townsville. He's the clinical advisor to International Division of Australian Society of HIV, Hepatitis and Sexual Health Medicine. Mostly he works in rural and remote Australia, and he also manages the HIV and sexual health program in Papua New Guinea and some of the Pacific Islands. So he is someone who has years and years of experience in this field. My mother says the first time she heard the word epidemiology was from him in the early 1980s, and that's how he came on my radar to come on my podcast, so I connected with him. I hope you enjoy this episode and subscribe to the podcast if you haven't already, and most importantly, go buy my book. So without wasting much time, I think we can start. So typically what I do is whoever comes on, I shoot or the record the introduction beforehand so I can do a good job. But
Okay.
and I've already done that, so people have heard me say some words about who you are, but because it flew over my head, I would really like if you can just elaborate on the public health aspect, and then I can go into, well, I think it's nice to hear from you for a layman like myself of what is it that you really do, because there are a lot of words in there which may be confusing for people, like sexual health and public health, and so we've heard these words more and more over the last few years.
So I basically went to medical school, trained as a doctor, but I think health is much more than just a doctor seeing a patient.
Right.
And so when I finished my training in the UK, I went off to work first in Africa, where very quickly I realized that just seeing patients is not enough, because as you know, health is much more dependent on a lot of things. For instance, I saw one of your YouTube videos where you talked about using time productively, and you went out into the garden and did some yoga, and you said, the atmosphere, the sky was blue, and how the air was very clear. So I think you highlighted an important point there, where life is more about just illness and seeing a doctor. It's much more about how you live, where you live, what sort of things you do to keep yourself healthy.
Sure.
And essentially, that's what public health is about. So when I went to work in Africa, we weren't just seeing patients, we were also paying attention to food, to agriculture, to, clean water. And where I was, there was an epidemic of chest infections, respiratory problems.
Right.
And it turned out it was because at night, to keep warm, people are burning charcoal within their huts and so on. So they're breathing in carbon dioxide, carbon monoxide. So I decided then it was not sufficient just to be a doctor, that I had to sort of train in public health to understand better how people lived and what we loosely call the determinants of health, which are much more than medications, and if someone's got diabetes, giving them medication and stuff. It's much more than that. So that's how my interest in public health was first sort of kind of ignited. And then I think we met you when we were on our way to the Solomon Islands. And when we got to the Solomon Islands, it was actually even much more obvious.
And this
So
was in 1986, 1985?
1989.
Oh, 89 was it? Okay, right, right, yeah.
It was much more obvious that, for instance, I was in charge of a TV program, and it wasn't about seeing a patient and listening to their chest and giving them some pills. It was much more about the household.
Why is it happening? Getting to the bottom of why it's happening?
Yeah, why are people susceptible to TB? How do what happens when you live in a close household? TB almost mirrors, I know TB isn't a glamorous disease, but it almost mirrors what's happening with COVID-19.
Yes, I was going to quiz you on that later on, yeah.
And then I left New Zealand, I left the Solomon Islands and went to train in public health in New Zealand.
Right.
And that's where I trained in public health, and also was working on some sexual health programs. And so I decided to actually do some clinical training in sexual health.
Right.
So
tell me, how, so epidemiology is a part of public health, or is it vice versa?
No. Epidemiology is a small part of public health.
Right.
So,
that's what I was a bit confused about that aspect. So epidemiology is, of course, it's the buzzword these days because of what's going on with COVID and coronavirus, etc. So epidemiology is essentially, an epidemiologist is someone who studies infectious diseases.
Not only infectious diseases, but also non-infectious diseases. For instance, India has one of the largest populations of diabetics in the world.
Right.
So it's about understanding, what the population distribution is, who gets diabetes. So you might say, for instance, I'm not saying this is true in India, but you might say, for instance, diabetes is a condition of men or women between the ages of 30 and 60. Then you'd look at the distribution and see how it's distributed in the various age bands. You look at possibly whether it's one type of diabetes versus another type of diabetes. You look at racial distributions, because no population is homogeneous, except if you be in Japan or somewhere, one of those places. Most populations are heterogeneous.
Right.
So it's the same with infections. If you take COVID-19, you've got an outbreak. You want to understand who gets it, the age, sex distribution. You want to understand how people get it. And so all that is epidemiology, the description of conditions, whether they're infectious or non-infectious.
So it's about all disease, not just infectious disease, but I guess it's being taken quite literally for infectious disease at the moment, because that's what's on everybody's mind. And and trust me, that's the last thing I really want to, keep harping on my podcast. But it's just that, there are so many unanswered questions, and I I've strayed away from, and I always have, and I've typically stayed away from mainstream media because unfortunately a lot of what they say is bullshit or is
Mm.
fake news or is paid for news, and there is some agenda behind it. But this time I've been following a little bit of mainstream media and a lot of parallel media like podcasts and
Sure.
some YouTubes, and the information is, it's like chalk and cheese. That's why I've got so many things to discuss with you. From some people say wearing masks is totally useless unless you're a surgeon who's wearing it and he's wearing it to prevent the infection he's giving it to his patient. Some people are equating wearing masks with trying to stop a mosquito with a chain link fence. Impossible. The
Yeah,
others are
sure.
saying, but the rules are, I mean, I can't step out of my house in Delhi without wearing a mask. Nobody's really checking what kind of mask am I wearing. Am I wearing it like this or this? Or, half
Yeah.
the staff at home is sometimes wearing a mask, sometimes not. They're tying handkerchiefs. I mean, there is just so much information that is available to us, and who do you really trust? And even this was a question like really further down in my list, but I guess it's a relevant time to ask you that there is just so much conflicting information. How does the layman get life-saving information at this time?
I think the one thing you have to do is you have to move away from social media, because information on social media can be exaggerated, or Google can be exaggerated. For instance, today I saw a patient and they had a certain condition, and they went, yes, I said, did you Google it? And they go, yes, I Googled it. And I said, there are 3 million different pieces of information about this infection on Google. Most of them are absolutely wrong. Essentially, what you have to do is you've got to log into, and there are certain websites, that do give you good information. So if you're taking COVID-19, CDC, WHO, and there are other non-governmental organizations that give you good information on COVID-19. I told you in my bio that I'm a um, advisor to the International Division of the Australasian Society of HIV,
Right.
Hepatitis, and Sexual Health. I know
Mm-hmm.
that's a bit of a mouthful, but we've been working on some regional protocols to disseminate information. Most of the people that we work with, the people that I work with, live in remote locations,
Mm-hmm.
and the health workers there often don't have access to the internet. So we've got to try and find ways of delivering information quickly, without excessive cost,
Sure.
because data, a phone costs a lot of money. So we try and do that quickly. So we've come up with a whole series of short messages, which we pass through a whole lot of scientific people to make sure that we're giving them the right information. So
Right.
there are reputable outlets out there. The other mainstream newspapers and media organizations like the BBC, for instance, if you look at global newspapers like The Guardian, Weekly, and so on, they do tend to research the information reasonably well. So
Mm-hmm.
you can actually trust those sites. Today, I think Google's put on, because Trump's been um, tweeting a lot of fake stuff, they've put on fact check. So I don't know whether you can trust Twitter, but what I'm trying to say, not very elegantly, is that trust some of the mainstream stuff
Right.
and avoid the social media, because otherwise you get conspiracies about, you know, 5G and all sorts of
Yeah,
things.
so there's a ton of that I've also I didn't want to bring it up at all because I don't want to get banned off YouTube. I've just started out, and so I can be transparent about it. There's a bunch of
Yeah.
stuff that I have read, heard, perhaps some that I do agree with as well, but I can't speak about it. But having said that, hasn't
Why
it,
no? Why can't you speak about it?
because I know a lot of people who have this video will be taken down from YouTube, as simple as that. the moment I try and make a connection of 5G and even I'm not saying I believe that. Do I believe that 5G creates problems in a person's immune system? Yes. Do I believe that 4G and 3G do it? Yes, they also do. I mean, any sort of EMF radiation causes issues in the human body. This is something we're dealing with that didn't exist when we were cavemen and when we didn't have this technology. So this is all new stuff that we're having to deal with. The same way, we didn't have GMO crops and etc. So this is a rabbit hole that I don't want to go down at the moment with you. But I was just going to ask you that hasn't the WHO?
I can just tell you. Let me just tell you that I argue with my son all the time. So you can throw anything you like about it, and I'd be more than happy to.
All I'm going to say is that the word conspiracy theory was coined. There was a conspiracy to coin the word conspiracy theory by the CIA when JFK was assassinated, just so that they could neutralize any other narrative that was coming on board, because they wanted everybody to stick to, this guy did it. You know what I mean? So even the word conspiracy theory, there's a conspiracy behind coining the word conspiracy.
Yeah, okay.
And I love reading about this stuff, but that's not what this podcast is about.
Sorry.
But
I'm distracting you.
That's cool. I'd love to talk to you about this, and we can do a part 2 of this podcast just on COVID conspiracy theories. But hasn't the WHO got it wrong several times? And that's one of the things that is kind of being brought up even by some of the mainstream guys now, that the WHO said this and then they said that, and then so is it that they have no idea what's going on, or there is some sort of the other explanation is that there was an agenda to kind of not, give the exact information initially. And I don't understand why that would be.
Look, I think that WHO is a good organization. We often use a lot of their work, which is incredibly reputable. Mm-hmm. I think as far as COVID-19 is concerned and the spread of COVID-19 is concerned, it happened very rapidly. Right. And I do not, having worked with bureaucracies, I don't believe that any organization would have had the capacity to react as quickly as that. I mean, the outbreak, which started in Wuhan, was so extensive. Mm-hmm. And I think with outbreaks, often, sometimes countries, cities, public health departments get caught unawares, and COVID-19 spreads really, really quickly. I mean, you may have seen. I think just a couple of weeks ago in I can't remember whether it was in Apple News or somewhere else. They said a man had spent 2.5 hours in a restaurant and infected 52 people.
Right. I'm actually not surprised by that number, because we do know that it's extremely infectious. Sure. And that was actually, so please continue. Yeah.
No, and you've seen all the in Australia, a significant number of the infections have been related to cruise ships.
Right.
And, these are incubators of infection. And remember, coronavirus, the coronavirus is spread through respiratory droplets. So anyone within 2 meters of someone has a reasonable chance of being infected. So coming back to the original thing, I'm not sure we can, say that WHO didn't react fast enough, reacted too fast, too slow. I think it's not possible in the midst of an outbreak like this to make those observations. I think what we have to do is go back and say, at some point in time, what happened? How did the various organizations behave in these situations? And how can we now plan for the future? Because coronavirus is only one virus. There are lots of other viruses that are emerging all the time.
Right.
We'd like to think that we can protect ourselves. We can't. We simply cannot protect ourselves. We have to, a significant proportion of human infections have emerged from animals, and they're called zoonoses.
Yes.
And we can't protect ourselves from that. Viruses will emerge all the time.
But we've survived for thousands and thousands of years because as human beings, we're equipped to deal. We're made up of millions of viruses, what I'm led to believe. And we're constantly, our immune system is constantly learning about new ones. Then the process starts since we were born. So why is this? What is this? And how much do we know so far in terms of why this COVID-19 has, become a superstar of viruses versus, like the swine flu or versus any other flu?
So we know that the virus has emerged from bats. Okay, that much is clear. But we don't understand what the intermediate host is. I know everyone talks a lot about the wet markets being responsible for the transmission of this virus, but we don't know what the intermediate host is. So we know we've got the virus in the bats. We know we've got the virus in human beings, but we don't understand what the intermediate host is. Could it be pangolins, which are a mammal? We don't know. Could it be because people have been eating bats? And I don't know if you know about the theory of HIV, but we think that HIV emerged, it adapted to human beings. But again, we don't understand what the intermediary process was. So I think to sort of say, oh, well, it's emerged because of the wet markets in China is a bit too premature. We simply don't know. I think that in the midst of a pandemic like this, people want answers, but we can't give those definitive answers, and that creates uncertainty. But generally speaking, Yameer, life is uncertain. There are no certainties, and even medicine doesn't have a huge amount of certainty. We like to think that you go and see a doctor, they can fix you. You've got a particular condition, they can fix you, but there's a lot of uncertainty around it.
Sure.
I think with the coronavirus, we've had over 5 million infections, 350,000 deaths. We'd like some certainty. I'd like to know what's happening, how it's happening, who's in control. Hey, that's an exercise in futility.
And just to step back, so it's 100% confirmed that it's come out of bats, right?
Well, that's what we think the origin is, because it's similar to
theory. Sorry to interrupt. It's a theory that it's come out of bats.
So I think there are some scientific certainties. So we know that it's a virus that's emerged from mutation of viruses in bats. How it transmitted and mutated in between to reach human beings is not very clear.
So that brings me to my next question: was it man-made? Because that's another, and I wouldn't even call it conspiracy theory, because a lot of mainstream guys are saying that no, now we know it's come out of the lab, it leaked out of the lab in Wuhan, and blah blah blah. So is there any evidence to justify that?
I'm only a doctor, but I will go by what the CIA says. The CIA says that they don't, and the U.S. intelligence agencies say that they don't believe it's come out of the labs. So, that's what they're saying. Has it come out of a lab? No, I don't know. But, when you reach back to the old days, not so long ago, they used to say, well, HIV has been transmitted because, through the polio vaccine. And there were all sorts of conspiracy theories about HIV as well. So I simply, I'm not saying that it hasn't come out of a lab, because you can never, refute any statement to its absolute. But the evidence at this point indicates that it hasn't. But who knows what will happen down the track? I mean, will there be more evidence which suggests that it's come out of a lab? At this point, there is no evidence to suggest that someone in Wuhan or wherever actually manufactured this virus and
Yeah,
it
it's
got
a
out of control. I
bioweapon or
mean,
whatever.
it's a convenient narrative,
Hmm.
but there's no evidence for it.
Well, the latter part of that question, which I'd written down, was I wrote, does it matter? Because isn't it what's
No.
more important at the moment is dealing with it, solving the world's problem, or focusing on solving problems rather than, I mean, it doesn't matter really, right? Did it came out of a lab or not? And for someone like yourself or the rest of the, the scientists and experts all over the world who are working on this, it's just they're just trying to solve the problem. I really don't think they care whether this came out of a lab or not, unless it
And
helps to know in some way and you can tweak the way you look at it, the solution. I don't know.
yeah, man, I mean, you hit the nail on the head. Doesn't matter where the viruses come from. We have to deal with the consequences of it. And I think it's very simple. To say it's come out of China, it's come out of a lab, you know, if people are certain about it, it might give them a bit of comfort.
Mm-hmm.
But essentially, it's bullshit.
Mm.
It doesn't matter. Who knows? It's there now. It's like, we've got a lot of infections which have basically are zoonoses, which have, come from animals, have mutated, and now are present in humans.
Right.
Does it matter how it happens? No. We have to deal. We have to deal with the situation,
So,
not with the theory of how it
this
emerged.
reminds me of I was seeing. Well, obviously, the one of the most popular movies to go back and see now is Contagion. I don't know if you've seen that. And in that, when their particular thing, the disease is spreading, the head of the CDC is called in by one of these army guys for an emergency meeting, and he says, "Do you think somebody's trying to weaponize the bird flu?" He says, "Nobody needs to weaponize the bird flu. The bird's already doing that."
Yeah.
So I found that quite amusing, and I remember that at this stage. Another thing we had discussed when we were planning to do this, when I was speaking to you over the WhatsApp call, was your view on this whole situation globally versus this lockdown versus the slowdown. And because again, there is so much conflicting information and governments are learning on the fly now, I think there is a pretty clear tilt towards the fact that the lockdown doesn't seem to be working, and the slowdown that's been created because of the lockdown in economies is perhaps going to end up killing more people than the disease, especially in
Yeah.
a developing country like India.
And this takes us back to what we were talking about originally about the determinants of health.
Mm-hmm.
This is a virus that we have to live with. In my view, I'm not someone that's high up in the global bureaucracy, but it's pretty obvious that this is a virus we have to live with.
Mm-hmm.
And if you look at the epidemiology of it, coming back to that big word earlier,
Mm-hmm.
up to CDC says that up to a third of people have no symptoms.
Right.
And then some people will have mild symptoms, some will have moderate symptoms, and some will have severe symptoms. And the severity of the symptoms is related to chronic medical conditions like, unfortunately, if you are much older, your immune system is less responsive. If you're a diabetic, if you're overweight, if you've got cardiovascular conditions, renal, kidney problems, all the rest of it. So I don't think it's possible to lock down societies. If you lock down a society, as soon as you open it, the virus will come in.
Right.
Because Australia is relatively lucky. We're an island.
Mm-hmm.
And the government here locked down very early.
Mm-hmm.
We stopped the international flights, and we were in Perth when this started to happen.
Mm-hmm.
And our daughter, had to get back to London because she worked. We got her on the second last flight out
Right.
to London.
Right. Mm-hmm.
Right? They locked down completely. And in fact, anyone that came in had to either initially go into self-isolation and then into quarantine.
Right.
but we're an island.
Mm.
So you can lock down an island, and we've only got 25 million
Yeah, I
people, for
was going to say
Christ's
the
sake. I
population
mean,
is not really that's
no,
like,
and
I've got 25 million people in this vicinity probably, like just, yeah,
exactly.
my back door is 25 million people.
Exactly. Yeah, I mean, that's that's my view too. So you can lock down a society where you've got a few people who live. I mean, we've got a lot of space here.
Right, yeah.
Okay. I mean, I live in a town of 200,000 people, which doesn't have a lot of people coming in at all. And all the cases we've had have been imported from overseas. You
Right.
can do that,
Mhm.
right? But as soon as you open societies up again, as soon as you open travel up again,
Oh,
I
yeah.
mean, for instance, we've got a ship, and I forget, it's a maritime ship that's come into Western Australia. Um, and sorry, forgive me, I can't remember whether they were bringing something in or taking something out. And 7 or 8 of those people have COVID-19.
Right.
So
The
we've
crew?
isolated them. But if we hadn't isolated them and they'd come on shore, they would have infected other people. So it's not possible to control this virus.
But I
It's not
think
like
what's...
it's not like HIV, which
Mhm.
is sexually transmitted.
Yes.
So,
Yes.
you've got 2 people having sex. There's a certain probability, 1 in 1,000, if you're a male or a female, that you can transmit the infection. This virus can infect a lot of people
Right.
simultaneously.
Right. And that's when the fancy are not words come into play, which I've had to educate myself on. So can you just speak a bit about that in terms of what we know, basically to ask how infectious is this really, or what we know so far?
So RO that you talk about is what they call the reproductive rate. So the reproductive rate is a product of the transmissibility versus people who are susceptible. It's just a mathematical model. If you've got a reproductive rate of greater than 1, it means that one person can infect more than one person, and that can lead to an outbreak. If you've got a reproductive rate of less than 1, that means one person infects less than one person. So what that means is that over time, the infection may not necessarily disappear, but it's not going to cause too many issues. So that's what they mean by the reproductive rate. So the reproductive rate of COVID-19 depends on where you are, depends on the vicinity of people, depends on the number of people around. But effectively, they're saying it's around between 1 and 3.
Right.
So one person with COVID-19 can infect around 1 to 3 other people.
Right. And so when we know that this is as infectious as it is, and there's no debate about that, and so are governments or are people really gullible enough to believe that by locking people down, they're never going to get it? Because what I'm led to believe is that either we've already had it or we're going to get it in the near future, not even the distant future, in the near future.
I think, Yameer, that's an excellent observation. And I think, what will happen is that, yes, we lock down, there's a damping down of the outbreak. But then as soon as people start moving around, they're going to be exposed to the infection.
And
so
it goes right back up then. Yeah.
So it goes, you're going to have waves of the infection. You're going to have outbreaks of the infection. And of course, it's right that the public health authorities, whether they're in India or in China, then try and control those outbreaks. The reason for controlling those outbreaks is to reduce the number of people at the severe end of the spectrum.
Right.
Okay?
Yeah.
Because no society has enough medical support at the severe end. So for instance, Australia only had at the start of the outbreak, we've got a lot more now, but at the start of the outbreak, we only had 2,000 or 3,000 people who were who could be ventilated.
Right.
Now I think the number is up to 6,000 or 7,000.
You mean because of the limitation of machines, the number of machines? Or?
Yeah.
Okay.
Yeah.
Okay.
We don't have enough ICU capacity. So, some people will have no symptoms. Some people will stay at home and they have moderate symptoms and they can mild or moderate symptoms. They get over it.
Mm-hmm.
Like I'm sure you've had a cold from time to time, and sometimes it's mild, sometimes it's severe, right? You suffer for a few days, but you get better. Then there are people at the other end, people who might just get away with just using oxygen, But then there are people who need to be ventilated. And those people who need to be ventilated need to be in supported circumstances. You can't just set up a ventilator in Chani Chok, for instance. That's not possible.
Right. I understand.
You have to be in a high-tech, and the idea of damping down things is to reduce the number of people at the severe end of the spectrum.
Right.
And it's what they call, I'm sure you've heard the term flattening the curve.
Flattening the curve, yeah, of course. Yeah,
that's what they're trying to do. They're not trying to get rid of the infection. It's not possible.
Right. And I think that's an important point, that to understand that it's only flattening the curve makes sense to me, not to overwhelm. Like they've been like flatten the curve, don't overwhelm the NHS system, don't overwhelm the Indian healthcare system. But two things.
It's any healthcare system.
Any healthcare system, yeah, of course. That's why they want to flatten the curve, so that at any given point of time, no hospital or no medical facility is overwhelmed by the number of people. But that's just 2 points related to that I wanted to come to. One, you spoke about ventilators. Now, apparently 90% of the people who have been put on ventilators for this haven't made it. So there is a big debate about whether ventilators are a good, life-saving tool for this particular disease. And in continuation of that, because a lot of doctors that I've been listening to, and some of them are really big, and I heard like a 2-hour podcast on Tony Robbins did a podcast, and he got people from Stanford and Cleveland Clinic, and these are the who's who Nobel Prize winning guys.
Of course.
And honestly, they were basically saying that ventilators are not working for this. It is presenting itself as a kind of, people are presenting themselves as someone who's got decompression sickness, or someone who's, been left on top of Mount Everest without acclimatizing, and some sort of hypoxic. I mean, I don't know the technical terms here, but basically they're saying that they need oxygen, not a ventilator. And effectively, you put the guy on the ventilator and 90% of them are going to die. And this isn't a mainstream podcast by some very, very big guys saying this. So that kind of threw me back, that essentially they said a ventilator is a death sentence for these guys.
I think that's the problem. One of the things that, and this is where there's a limitation in our understanding. I mean, this is a massive outbreak. We understand very little about the virus, but you will have, I don't know if you've heard of this term cytokine storm.
Yep.
Yeah. So what tends to happen is that there is an enormous inflammatory reaction in some people. We don't really understand why there is that huge inflammatory reaction, but I had not heard, and forgive me, but I didn't realize that the mortality rate was 90%. I thought it was 50%, but
I think that statistic is kind of geared towards New York, that 80 to 90% of people put on ventilators died in New York. And even if it is 50%, I think that's quite a frightening statistic.
It's a frightening statistic, but I think, again, this is where epidemiology is useful. So you're saying, what proportion of people have severe infection? And that's not 100% clear yet.
Right.
And then you're saying that what proportion of people can get away with just using oxygen, which is what you were saying.
Right.
And then what proportion of those people require ventilation.
Right. Mm-hmm.
Right. And then if it is, if the rate is 1 in 2 or 1 in 1 in 10 that survive, it's actually a small proportion of the total number of people
Sure,
that become
sure.
infected.
I appreciate that part. Yeah.
So yes, it is a frightening statistic when someone says, look, there's 100% mortality or 90% mortality from ventilators, but you have to look at it in proportion to the population that's becoming infected. Not everyone who gets COVID-19 will end up in that situation.
Right.
And we're still learning. We just don't know because it's such a very early on in the outbreak, and I haven't kept up with the research, they were saying that the lining in the lungs becomes so severely inflamed, that that's what causes the mortality.
Right.
And I think we just don't know enough about it.
Right.
I'm sure there is some virologist or some immunologist somewhere working on it.
Mm-hmm.
But I was looking at the literature today. So I'm involved in PNG. We're trying in Papua New Guinea. We're trying to reassure health workers that the majority of people who get this infection will be fine. And I was just looking at the literature, and there is nothing to inform us about what tips someone over into the severity. We can say, yes, it's broadly diabetics, it's people with cardiovascular heart problems and, lung problems, but we don't know what are the specific factors that tip people over into that severe category.
Right. So a second part of that, first was about ventilators. We were talking about lockdown versus slowdown, and then you mentioned a few things.
So what is actually interesting, sorry to interrupt you, but what's interesting is that we've had lots of innovations. So people are now making ventilators out of all sorts of recycled materials that could be used. Doesn't need to be an ICU.
Okay.
It could be just a supported environment. So a ventilator is complicated to some level, but if we can simplify the technologies, which apparently some groups are working on. There's a group down here in Australia, in Brisbane, that's working on a very simple ventilator that could be used in a whole variety of different circumstances. So amongst all this carnage and chaos, we've had progress which we will benefit from in the future.
Right. But typically when you ventilate a patient using a ventilator, I believe that there are 3 or 4 different doctors that have to look after him. There's an anesthesiologist, there's I think the main physician, because you're literally putting the guy in a coma. I mean, I don't want to be crude about it, but that's what it is, right? You have to put the patient in a comatose state in order for the patient to accept that violent procedure, if I can call it. It is a bit of a violent procedure.
Well, how can I put this, Yameer? It's not a violent procedure. Well, because lots of people get ventilated. You have someone may be involved in a massive road traffic accident, and they, in order to help their recovery, you might need to ventilate. You might need to put them into a coma, if you like, and ventilate them whilst they're recovering to a degree. There are many, many conditions in which we actually put people into intensive care units and we ventilate them. Thank you for pointing that out. I hadn't thought about it as a violent...
I'm just trying to think because, I'm an asthmatic. It's easy to get me claustrophobic. So, thinking of something being shoved down my throat, of course, to keep me alive, apparently, but it's just comes across as like a violent thing to me. But
it's how can I put it? It's not really just shoving a tube down your throat. It's they tend to do it in yes, in some situations you have to do that, but in other situations they try and do it in a controlled fashion to cause as little trauma to the to the patient as possible.
Sure.
But I think you're right. I hadn't really thought of it as a violent act. But
Well, I would not want you as a doctor to think of it as a violent act, because you are
no. But
you
it's
are looking at saving lives and their moment, and I'm sure like you're not bothered about, is this guy going to feel this injection?
no. I think it's important also. I mean, thank you for pointing that out, because sometimes we don't. In that situation, you don't kind of think about it from the patient's point of view. You're kind of thinking, as you said, what can you do to get this person ventilated and oxygenated as fast as possible.
Sure. So my second point around the lockdown was going to be, how do you build herd immunity if you've locked down half the world? And what is herd immunity? And again, this is a word that suddenly is very popular. How does that happen? Because,
well, I think, again, you ask an impossibly good question. Even Sweden, which didn't go down for a lockdown, only 7% or 7.5%, it's around that number of people had antibodies. So the question is that if only a few people develop antibodies, and this comes back to this notion, well, what works, what doesn't work, we don't know. We don't know which antibodies are protective and how long they're going to be protective for, and whether you can get the virus, whether you can get the infection again.
Yeah, that's a question I wanted to ask you, that because this is a discussion within the family, that once I've got it, am I not immune? Can I get it again? Or will I get it to a less severe extent? Is the scary answer that we just don't know enough yet?
No, we just don't know. You can tell your parents and everyone you live with, life's a bitch, and then you die.
That's a good comeback. I'll make a note of that one. Life's a bitch. And yeah, but that's quite scary for me to hear, because typically we've been taught to believe that once you get something, you kind of become immune to it, and that's how vaccines so-called work, and etc.
Now, again, you raise an interesting point. We don't know how effective or useful coronavirus vaccines are going to be if we ever get a vaccine that works. Right. We also don't know whether we're going to have to vaccinate people every year, and then if the virus mutates, will that require us to, like the flu vaccine, you have to have a different flu vaccine every year.
Right.
Yeah. What I would say to you is that, what we're doing here is we're vaccinating all our patients. We're trying to vaccinate the population against flu, because you don't want to get flu and corona at the same time.
Right.
So there are lots of unanswered questions about the coronavirus, and anyone that says to you that they know,
they're talking crap.
I think they're being economical with the truth.
That's a good way to put it. So in terms of herd immunity, the answer is that we don't have the answer at the moment. Is that what you're saying?
Well, I think that's true. Epidemiologists will unpack this over a period of time. The virus only emerged last year at some stage, so we don't really have the answers. We don't even know what herd immunity means in the context of COVID-19.
Right.
I'm sure you'll find an expert out there who will tell you that if we can get herd immunity, things will be fine. The question is, what does herd immunity mean? Now, it's much simpler if you're talking about measles, mumps, and all those things you might have been vaccinated against, because measles is a very stable virus.
Right.
It took us a long time to get a vaccine. The issue is not how effective the vaccine is. The issue is what proportion of the population you vaccinate.
Okay.
Right. Then with some vaccines like the whooping cough vaccine, we know that the immunity wears off after a period of time, and you have to re-vaccinate people.
Right.
But we don't have that information about COVID-19, not yet anyway. In a year it might be different, but at the moment we don't have that information.
I was reading somewhere that one of the experts out of New York, a doctor, who was saying that it's essentially, I don't know now, he said it's a cousin of the common cold. Have you ever heard of a vaccine for the common cold? And because it mutates so many times, there can't be can't be a vaccine for the common cold. So how can there be a vaccine for COVID-19?
And I mean, I think he's right. I mean, this is, I hate to call this a variation of the common cold because it can be quite a severe infection in some people. And I think like the viruses, the respiratory virus, the common cold or respiratory viruses, there's quite a group of them that can cause the same symptoms that you get in the upper respiratory tract.
Okay.
And of course, in its mildest form, this, the coronavirus could fit into that group.
Right.
But I think it's a brave person that calls this a cousin of the cold. Again, I'm sorry to sound so boring, but we just don't have enough information.
No, but boring is good because boring is factual in terms of, I'm glad that there is someone with your repute and your background who can say that we don't know enough, rather than just saying that because I am XYZ, this is my theory and I have the answers to all the questions. Yeah. And that's what a lot of people are trying to do, is just that, I'm Nobel laureate from XYZ place, so this is my theory, this is my answer. And if he's proven wrong, it may cost lives.
And look, there's a lot of people out there who, in the context of the outbreak, are saying a lot of things. Mm-hmm. But the problem is we don't know how true those things are. And what someone is going to have to do eventually is, and there are certain very reputable groups, like one of the sources I use it's called Up to Date. Okay. It's an American source. Up to Date, UPTODATE.
It's a website?
Yeah, it's an American medical resource.
Right.
And what it's doing is it's updating almost weekly.
Right.
Information about COVID-19. So I forget the author's name, but what he's doing is he's looking at all the stuff and he's going every week, he's updating it, and he's going, this is what we know, this is what we don't know. For instance, you may remember a few weeks ago, they were saying, oh, you might be able to get COVID-19 from cats or some animal transmission from some.
Yes. There was something, I can't recall which animal it was, but yeah.
Yeah, well, that's right. I think it was cats. And again, there is zero evidence for that.
Okay.
So what I'm trying to say in not too elegant a fashion is that a lot of people are having opinions, but you don't know you don't know what the validity of those things until you have hindsight.
Right. Understood. And that's going to be a painful one in this case, by the looks of it, because
5 million people have the infection, 350,000 people have died. Mm-hmm. It's painful. I had a patient today who was saying, oh, I've got this pain, and I said to him, look, I don't know what's causing the pain. We've, looked at this, and this, mm-hmm. and we can't find a reason for your pain.
Right.
And I don't know where to go from there. Right? I can send you to a colleague of mine who might be able to review what we've done. Mm-hmm. And if she can find a reason why you've got this pain, I'm happy to go with what she finds. But medicine is uncertain.
So is it a lot of hit and trial, especially with things like this?
Look, 85% of what we know is hearsay.
Right.
Depends on imperfect evidence, on uncertainty of what's happened in the past, of our experience. But you only know in hindsight whether those things have any validity or not.
And in terms, you were just speaking about diagnosing one of your patients. So I had a couple of questions, which I mean, I've had forever. And again, a lot of conflicting information. The test that is being used now, there's a lot of debate and conspiracy theories and all kinds of stuff on the test itself, which was originally developed in China. They used lung fluid from 7 symptomatic people to develop this PCR test. I don't even know what PCR stands for, but I'm sure you can educate me on that. But now apparently the whole test, the bloody test is flawed. What are your views on how this is being diagnosed and actually tested for? Because you've got the same people, like positive, negative, positive, negative. I mean, it's like a coin toss almost. In some cases, I know of people who have been tested positive and negative within the same kind of 1 or 2 week time frame. How is that possible? Or is there's something really wrong with it?
So that's the other thing, people often believe that if they've had a test, that there's 100% certainty around whether it's positive or negative.
Okay.
There is not.
Oh God. That's more bad news though.
Sorry.
That's bad news.
Are you sure you want to hear me talk?
Yeah.
So if you take let me start off by saying what a PCR test is. So what happens is that COVID-19 is an RNA virus. Do you know what RNA and DNA is?
Yeah, but can you please educate us on that? Because these words have been...
RNA, it's the genetic material. Just putting it simply, it's a genetic material. So what they do is they take a little bit of that genetic material and they amplify it.
Right.
So, like they put it in they have media, they amplify it. So even if with PCR tests, they're called polymerase chain reaction tests, you can take 1 or 2 bits of genetic material from an organism, and then you can amplify it. So you get billions and billions of different pieces. And then what they do is they take that amplified organism and they add a color to it. So it can tell you whether it's positive or negative with a color change.
Okay.
Now, so not all tests are the same. Just like not all cars are the same.
Right.
So I don't know what sort of car you've got, but say I'm dreaming here. Say maybe you've got a Lamborghini 4-wheel drive, right? That you're driving around Delhi.
Right.
If you hit something, you'll get millions of airbags coming out, right? Whereas if you're in a tuk-tuk, there's no protection.
Right.
Okay, so you can drive somewhere and you can be hit, and you're gonna, depending on the severity of the collision, God forbid, So all these tests are like cars. There are different versions of them, and in science, what we do is we try and validate those tests.
So there are lots of versions of PCR tests.
Yeah, so many people are using different versions of the PCR tests.
Right.
Okay. What I'm trying to say is that some PCR tests are robust.
Okay.
So they have they have the capacity to pick up the disease if it exists, and they have the capacity to be negative when the disease doesn't exist.
Okay.
But there's one further element to this. It depends on the prevalence of the infection. The prevalence of the infection means on the amount of infection there is in the community.
So is that the same as viral load? We keep hearing this word viral load.
No. It's a number of people who have the infection, right?
Tell me, why does that matter for a particular individual? I'm trying to understand that.
Okay, so
I mean, let's say I'm getting a COVID test now. Even if there are nobody around me has it, or in my community, why should
Basi-
that uh, why should that change my result, or have an
yeah,
outcome on my result?
because and anyone who tells you this is lying. No test is 100% sensitive or 100% specific,
Okay.
right? So sensitivity is you pick up the disease when it's present,
Mhm.
and specificity is when you pick up the disease when you can be truly sure that if the test is negative, you don't have the infection.
Right. Got it.
But whether or not you can interpret the test depends on how much infection you have in a community.
So you're going to be using your judgment.
No, no,
Uh,
no, no. It's called a positive predictive value.
right. Okay.
So
Okay.
again, it's an epidemiological comment. So even if a test is if a test is say 99% sensitive and specific,
Right.
if the population prevalence of the infection is low,
Mm-hmm.
then there is a risk of false positives
Okay. Okay.
and false negatives. So they call that positive predictive value
Right.
and a
Right.
negative predictive value. So every test you have done has a positive predictive value
Okay.
and a negative predictive value.
But is it fair to say that that is based on a probability based on number of infections in the community? So there is,
That's exactly right. So you're understanding it right. So
so, but there
whether
is
a test
some
is
amount of guesswork. I don't know. It just seems a bit like guesswork to me in terms of.
it's
I mean,
it's not
I'm just trying to
guesswork.
dumb it down. Honestly, I'm not trying to take away from the
No,
from
no, no.
the great people
Look,
who invented it. But
I mean, thank you for putting up with it. But I mean, thank you for putting up with this. But just because a test is positive doesn't mean that it's positive.
understood.
And just
Understood.
because a test is negative doesn't necessarily mean it's truly negative. And so where you get people who are getting false positives and false negatives, you're right. It could be because of the viral load,
Right.
but it could just be the test is crap.
And when you say the test is crap, now is there? See, in my mind, this is like a test is like, let's just dumb it down to like an equation or a formula. This formula was created in China, and everyone is just copy pasting this formula, or is it that countries have come up with their own formula, their own tests, and
Yeah,
that's why
so
some countries are better at it, and some, perhaps, I don't know, South Korea may have aced it versus and India or a UK is still struggling with it.
so I think you're asking the right question, and I'm sorry I don't have the answer for it. I don't know which tests are being used in um, in different countries.
Okay.
So you know,
But
the
in
test that
Australia, like the ones you guys are using?
we have um, is really hard to evaluate here in Australia because we don't have enough cases,
Okay. Okay. Right.
right?
So you don't
So
have the predictive value. Is that why?
we don't have a predictive value. So even if a test is 99% sensitive and specific,
Mm-hmm.
if the population prevalence of the infection is low,
Mm-hmm.
then the probability of having a false positive is high.
Hi. Understood.
I
Understood.
think what I'm trying to say, Yameer, is that I know this is a really difficult thing. Often have patients who will say, I haven't done X, Y, or Z, and my test is still positive.
Right. Right.
And
Right.
so what we say to them is, look, it could be a false positive.
Mm-hmm. Mm-hmm.
You can't rely 100% on the result of the test.
Okay.
It can give a patient comfort, or gives a doctor, in fact,
Yeah.
comfort, right? And most doctors simply, with all due respect to them, they don't understand this issue. That no test has 100% positive predictive value.
Mm-hmm.
No test has 100% negative predictive value. And
Understood.
that's even more true with infections and
Right.
PCR tests.
Right. Right. Now, is there a way to look at this? Or I don't know, are you aware of anybody looking at just, and I don't want to call it reinventing the wheel, but maybe a better way to find, or does the technology exist to have a foolproof way to check this out, or it doesn't exist yet? Just to get 100% accurate result?
I'm sorry, I mean, I can't answer that question. I'm sure there are labs around the world that are actually looking at they're looking at these tests, and they're looking at all the various probabilities around the test.
Okay.
So, you know, what I could do is just email. I know the local person in charge of the lab. I could email them, and I can give you some. I could email back you some.
Yeah, I mean, it's just out of interest, and maybe I can put that in the show notes of the podcast, because I just think the diagnosis and testing is such a critical component of this particular epidemic or this disease, because so much of life now is dependent on the fact: are you positive? Are you negative? Can you travel? Can you not travel? Can I cross into my state border? I have to quarantine. I have to show them a test. Can I get back to my office? Can I get back to doing anything? So this is why, and of course, generally, and this test is relevant to the broader discussion about herd immunity and people just getting back to their lives, which is why I wanted to but I've got a good understanding of what this is now, thanks to you. And this positive predictive value is a good.
I don't think there's any value in saying, look, I've had the infection and now I'm immune, so I can go back to doing whatever I want. I can travel to wherever I want. We simply don't know.
Yeah, I appreciate that. I appreciate that point a lot. And in the middle, now in India, they were saying, oh, you know, it's now the peak of summer's hitting, and because it's hot weather now, it's like 45 degrees Celsius at the moment, right outside this door where I'm sitting. Is that going to help to reduce the infection rate, or again, we don't know enough?
So again, Yameer, I don't know. You know, the problem is in the winter, you're cold, and a lot of people are much more together. In the summer, they tend to spread out. Will that affect the transmission of the infection? I'm not sure. Mm-hmm. You know, I think we're all, after the summer is over, you will have a better idea of what actually happened during the summer. But the virus isn't going to go away. I mean, maybe there will be a decline in the number of people becoming infected. But as soon as winter hits again and people are in close proximity, you know, the issue is close proximity.
Right. So it's nothing to do with the fact that it doesn't survive much in hot weather, or these are just, again, people who are doing, this is conjecture.
Again, it's conjecture. I mean, we don't know. I mean, so you know how they were saying a few weeks ago, if you know, cough onto a door handle or, you know, cough onto a surface, the virus can survive.
For up to 6 days, I was told, on a doorknob.
Oh, look, I don't know how long they were saying. The problem is, yes, the virus may survive. The question is, you know, if you touch that surface, will you get the infection? And the evidence now, or some of the observations now, are suggesting that that may not be the right thing.
Right. Okay. That's encouraging.
So, you know, so all this stuff of, you know, deep cleaning and all the rest of it, does it make a difference? We don't know.
Okay. And you know, the security staff at the gate is sanitizing Amazon deliveries that come every day, and they're like, you know, like, and then they put it in the sun for 2 hours, and so we've got a little bit of a mini, you know, containment unit thing going in our own house. But I guess everybody is, and unfortunately, it's because of fear, and we don't know enough, right? So we're like, what's the harm? Okay, just spray it down with Dettol spray, and then leave it in the sun. And they did that with some chocolate that I had ordered the other day. So that went straight into the bin because I forgot to tell them that there's some food in there, or there's some edible in there. But, you know, that's just on a lighter note. But I think...
Look, Yameer, it may turn out that it's, you know, again, it may turn out... science and medicine goes around in circles. You can make a certain observation, and another group may make a negative observation. Another group may make a slightly positive observation. Another group may make a negative. And at the end of the day, you have to pull all this data together. It's what they call meta-analysis.
Right, right.
Where you pull together all these various studies and then you try and make sense of what is happening.
Okay.
So you've got to have the negative studies as well as the positive studies. And at the moment, we're yo-yoing. We're saying, it might do this, it might do that. But in 12 months, the story may be completely different.
And you mentioned that this is here to stay and, this is not going anywhere. So I learned a new word yesterday called endemic. Can you just maybe speak about why this epidemic is going to become an endemic?
So epidemic just means that you've got increasing numbers of cases and you try and cope with them. Endemic means it's become embedded in the population.
Like swine flu now, because every year we have swine flu in Delhi now. At least in Delhi we do.
Yeah.
So we just live with it and we're not afraid of it and we're not sanitizing the hell out of each other.
Yeah.
So is that where this is? I mean, I know this is just a guess. I know it's a guess.
Endemic means it's embedded in the population. You just have to live with it.
But the science and your experience says that this is where it looks like this is going to become an endemic and we're going to have to just live with the rest of our life.
All infections have become endemic. I mean, a lot of infections have become endemic. Like, for instance, you mentioned swine flu, but also other infections like, for instance, gonorrhea. You take sexually transmitted infections, syphilis, gonorrhea, all those are endemic infections. They're not going away. No population has managed to eradicate those infections. So if you get exposed to the and there's always within the population, there are always going to be people who are asymptomatic. Right? I mean, I don't know whether all those people at the gate have been tested, but some of them might be.
It's testing is such a problem in this country, city, at least in Delhi, and this is the capital at the moment, because I have to get a doctor's prescription for them to be tested. Obviously, the number of tests are limited. And if I get a doctor's prescription, then I have to, the doctor has to inform the local authorities, and then they're going to come and then they may just really seal my whole house. And I don't know. So I'm too, just see, nobody's symptomatic. So I don't really feel the need to get them tested at the moment, because they all live in-house at the moment. So we're not allowing any, we only, whoever's in the house right now lives in the house. And that was the condition when the lockdown happened, that there was some temporary staff that that was coming and going. We got rid of all of them and said, just sit at home and just sit at home, because it's not safe for you to come and go. So testing is a big process at the moment here. I mean, I want to, with my wife and my son, and my in-laws have a beautiful place in Goa. So we try and spend a lot of time there. And so obviously my son was about to start school. He's 3. Schools, we don't know when they're going to open. So we thought, okay, well, let's run away to Goa. But then there's this huge procedure of, we have to get tested in Delhi, then we may have to get quarantined in Goa. So I said, I'm not risking it. Let's just stay where we are. We're comfortable in our home here. Let's just.
And also, I don't know what tests they use in India. Again,
I'm not sure either.
We don't know how good they are at picking up people with infections, how good they are at picking up people without infections.
Sure.
So there's all that uncertainty around it as well.
Yeah, understood.
And the other big question is, why do some countries have higher death rates than other countries?
Right,
and again, we don't understand that. We simply don't understand that.
I was going to come to now in really the takeaway from all the podcasts and everything that I've seen, and I'm going to come to that now with you, is in the end, what can we do? I mean, is it just about keeping our immunity as the best we can, keeping ourselves as fit as we can, and just looking after ourselves and waiting to just ride this out, wait it out and ride it out?
Yeah.
And
I don't know. Look, I think in the end, you can say with certainty this virus is not going away. How can you best protect yourself? And for and for those things, we talk about having the appropriate determinants of health. Being able to have space, clean air, food, all those kinds of good housing, all those kinds of things can enhance your immunity. But a significant proportion of the world, and you'd see it in Delhi all the time, do not have the capacity to do that.
Mm-hmm.
I mean, you probably live in fairly good conditions. You can protect yourself. Suddenly, if you don't need to have to face people who are coughing all the time and all the rest of it. That's not, unfortunately, a condition that is available to the people that I work with. I mean, I work a lot with First Nations people here. I work overseas. It's just not possible to do that. So at the end of the day, we're very dependent on, I'm not quite sure what the right words are here, but I think we have to live with the virus. And unfortunately, most people will get away with it, and some people won't. And for a significant proportion of the world, it's not going to be possible to quarantine those people.
Sure. And
I know it's depressing, but I don't know how else to put it.
Maybe depressing, but I think there's also a lot of clarity in sometimes just hearing that we don't know the answer. And sometimes it's also because not knowing the answer is an answer versus having 1,000 answers to the same question. Like, I forgot to ask you about, I'm going to just come back to immunity in a second. I forgot to ask you, like, in terms of masks, now there's so much conflicting. What are your views? I mean, do I need to wear a mask or do I not need to wear a mask?
Look, the masks, if you're working with people who have the infection,
sure,
you need the appropriate masks, right? And then just putting on a mask is not enough. You've got to know how to put on a mask, how to take it off. So there's all this stuff around PPE. It's not simply just putting on a mask and just taking it off. I mean, things have to be done in a sequence. You have to have the right kind of protection. Cloth masks are useful if someone, what we've said in our clinic situation is that, if someone's really coughing, we don't want to see them.
Okay.
In places like Papua New Guinea, where I work, what we've advised people to do is if someone comes in and they're coughing, you can use a cloth mask. But
the person coughing, the patient.
Person coughing.
Right.
But not the health worker. Cloth masks in health workers increase the risk of acquiring coronavirus.
So does the health worker need to wear a properly fitted PPE? Yeah. Or are you saying that so obviously the health worker has to wear a proper PPE?
The health worker, if they're dealing with someone that's, got a cough of any kind, and it's often difficult to diagnose it as corona, it might be something else like TB, for instance.
Sure.
So, we say you need to have proper masks. If you don't have, and I've just written a short WhatsApp message that we're going to send out to our health workers. If you don't have masks, make sure that the person that you're seeing is at least 1.5 to 2 meters away from you.
Okay.
One. Secondly, when you're examining them or dealing with them, tell them that if they're going to cough, they should cough in a direction that doesn't face you.
Okay.
That you should sit asymmetrically, so you're not in their line.
Understood.
When you're examining them, make sure that their face is turned away.
Okay.
And so we try and do that because not everyone has access to the right sort of masks, and the right PPE for that matter.
But as someone who's symptomatic, I understand if someone is symptomatic, you're coughing, wear a mask. Even if whatever the hell mask you can get a hold of, just wear something to prevent that from expanding or spreading 10x, it's still going to spread through whatever you're wearing. Maybe it's going to spread 1x versus 10x. But so someone who's symptomatic should definitely wear a mask.
Someone who's symptomatic should wear a mask because it'll contain, you know, the spread of the respiratory droplets.
Okay.
But there is no evidence to suggest that health workers in a routine clinic should be wearing a mask.
Okay.
Just there's no evidence for that because not at the moment. And I know certain countries have said you can't leave your house unless you wear a mask.
Yeah, that's the rule here. That's the rule in Delhi. Yeah,
and
we can't leave without a mask.
Yami, the rationale for that is if the person is coughing or sneezing, is to contain it within the mask.
Understood.
And to some extent that does make sense. But the evidence that masks can stop this infection from spreading is simply not there.
Oh, what? Okay, understood.
Sorry.
No, that's fine. At least we've got that answer, and we discussed, and hydrochloroquine is of course been on because since Trump has been taking it. I mean, there's been a bit of a joke going on about that. And I know that you've dealt with this drug because you've treated a lot of patients with malaria over your experience.
I've treated patients with malaria. We also use it for arthritis.
Okay.
And it's a drug which is unpleasant, which can have effects on your eye. It can also sort of have effects on your heart as well. So it's not a drug that you should use lightly. And also you may have seen, I think yesterday or today, WHO has stopped some trials.
Yes, I got an alert on that a couple of days ago.
So people on hydroxychloroquine are dying earlier. So they've stopped the trials. And normally when you have a trial of a drug, you have endpoints. Normally if the drug turns out to be more toxic than you think, you simply stop the trial because the evidence is overwhelming. And that's the evidence with hydroxychloroquine.
And is it possible that a drug like hydroxychloroquine can treat malaria quite comfortably versus in this new disease that nobody knows much about, the same drug can actually create more complications? That's quite possible.
Yeah, it's completely possible. I mean, you know, we are talking about two different conditions, two different types of immunological responses.
Right.
Yeah.
But in terms of, so people are popping this or some people like Trump are popping this as a preventive. Doesn't seem like a good idea to you?
I'm not sure whether Trump is actually popping this drug or just saying he's popping it because he ordered the FDA to buy millions of doses of this drug. So I don't know. The man's impossible to read.
But in terms of a general healthy person, using it as a preventive is not a good idea in your opinion? No. Because it's a toxic.
Hydroxychloroquine is a fairly toxic drug.
Okay.
I mean, it's not like popping lollies. I mean, not that lollies are safe. I mean, the more lollies you pop,
Yeah, sugar.
Sugar. So it's not no medication is side effect free. I mean, there's always a price to be paid with some drugs.
Understood. Last couple of questions. We were speaking about immunity. So, typically I've been telling people is just mega doses of vitamin C and keep your vitamin D levels good. And zinc is a new one, which everyone's talking about. So I see no harm. So I just started supplementing with like a 50 milligrams of zinc every day. Any thoughts on dosages or anything else that one needs to do? Because I know that none of us get sufficient nutrients from our diet because we don't eat like that and we don't eat those quantities.
Look, I think generally speaking, if you're talking about diets, if you've got a healthy diet, you'll get all the stuff that you need from the diet. We in our line of work, I discourage people from taking multivitamins because most of the time you just pee out the
Yes.
multivitamins.
Yeah.
I there is little evidence to suggest that vitamins are the supplement, unless you've got a poor diet,
Mm.
that supplementing vitamins makes a difference. Coming to COVID-19, the evidence around vitamin C, zinc, and vitamin D is actually anecdotal and poor. So you made that point that yes, there is some peripheral evidence that suggests that vitamins like C and D and zinc can improve people's immune system, but it is peripheral evidence. It's anecdotal, and I know a lot of cricket mega stars and other people promote vitamins. Like Ricky Ponting here in Australia is an advocate for multivitamins, but the evidence is really poor.
Okay.
But what we have noticed, however, is that if someone's been on multivitamins for a long time and you stop them suddenly,
Right.
they feel really awful.
Right. Got it.
We don't understand the mechanism for that. So I often will say to my patients, look, you're spending all this money on multivitamins. You might as well give that money to me. I'll give you some colored water, and I'll say this is good for you, and you can take it.
So you think there's a bit of a placebo involved?
There is a huge. If someone who has a reasonable diet, then there's a lot of placebo involved in that. Okay. But there is what I was saying, there is that situation where some people feel really awful when you stop the multivitamins, but we don't know whether that's placebo or whether it's a real effect.
Okay.
And so often I will say, look, if you're coming off multivitamins or you're coming off vitamin C or D or whatever, let's do it slowly and gradually rather than, stop. So what I'm saying is, again, there's a lot of uncertainty about this.
Got it. And before I close, I wanted to ask you, I read the other day that there is again, this must be, I know I can guess what your answer is going to be, but like O blood groups, people who have O blood groups they're saying are not getting this disease. Is that possible?
It's possible. I mean, we know that people who have, it's not the blood groups themselves, but there are certain, so you have each cell in your body, like a white blood cell, will have a receptor on it that deals with an infection. And there are some people with certain groups of people don't have receptors on these cells. So it's not the blood group itself, but there are some other characteristics of blood groups that can actually predict whether someone will be resistant to an infection or not. And you've caught me on the hop. I don't know whether blood groups makes a difference. I don't think blood groups makes a difference. I think that the receptors that the virus, so there will be some people, the receptor the virus uses a certain receptor to enter the cell before it multiplies. Now, whether they're referring, there will be some people who don't have that receptor. So they will be resistant to the virus.
And it's possible that a certain blood group does not have that receptor, or it's a random...
not a blood group.
Okay.
It's a particular genetic characteristic.
Okay. So it's impossible to know who may or may not have that unless you test for it.
At the moment, I can't. Let me give you an analogy. In HIV, we know that if you don't have a certain receptor, which is called a CCR5 receptor, then the virus can't enter the cells. You can't become infected. You're immune to the infection.
Okay.
And I don't know enough about whether there are people around that don't have the receptor the COVID virus uses to enter the cell.
Okay. That's fair. And what I wanted to finally ask you was, in terms of what the future holds in terms of epidemiology and other diseases like this one coming on board and prevention of future pandemics and stuff like that? I mean, where is this area heading now? And I'm sure there's a lot of emphasis on that happening.
I think we have to learn from this outbreak. The world is much more interconnected now, and so the lessons that we learn from this pandemic will inform us in the future. We're not going to be able to stop viruses from emerging, but we may be able to contain them better. So it's as simple as that.
But there's no doubt that we will see many more of these always coming, because that's the way the nature works.
We will see many infections coming. There is no way that, and infections also mutate all the time. So there's no way that, it's the end. HIV has been around for 20 or 30 years and we still don't have a vaccine.
Right.
Malaria has been around for hundreds of years and we have a vaccine, but it's imperfect. Right. TB has been around for a long time. And we still haven't got on top of it. So there are very few infections that we've managed to control.
Okay.
Hepatitis B, we've got a great vaccine for hepatitis B, but it's probably an infection that causes a lot of problems around the world. So what I would say is uncertainty is not an enemy.
Yes.
Uncertainty is a way forward. Uncertainty allows us to open doors and understand things. Certainty encourages complacency.
Certainty encourages complacency. Wow, that's a good one to end on. Thank you so much, Dr. Arun Menon. So that was my chat with Dr. Arun Menon, and what I really appreciate is his ability to say that we don't know enough and that we're still learning as it goes. And that's a quality that I'm going to try and imbibe and take it from me, and not try and answer every question, especially when you don't. It takes a lot of courage to say, I don't know. And I think that is an answer in itself. Not knowing is more than having several answers to the same question, because when you have multiple answers to the same question, most of them are incorrect. I hope you enjoyed that long and informative chat of mine with Dr. Arun Menon. I have learned so much and got so many answers and closure on a lot of issues that were bothering me and that were on my mind about this subject in particular. I think what's most important and respectable is that he has the ability to say, I don't know. And he has the ability to educate us and tell us that no one knows enough about this at the moment, and about several of the answers, no one has those answers. So I respect that a lot. I hope you got something interesting out of this. Let's go away from this on a positive note once again. Get our immune systems ready for this. This is here to stay. And that's not necessarily a bad thing, because we are a resilient race. Human beings have survived for viruses and things like this for thousands and thousands of years. We're going to beat this one too. And life is going to continue as it always has been. Till next time, take care of yourself. Bye.
Voices in My Head is created and hosted by Yameer Adhar. This podcast is for information purposes only. Statements and views expressed on this podcast are not medical advice. We disclaim responsibility for any adverse effects that may arise from any information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for statements made by guests. This podcast does not make any representations or warranties about guests' qualifications or credibility. If you think you have a medical problem, consult a licensed physician.